My name is Stephen Swift, and I'm a urogynecologist at the Medical University of South Carolina in Charleston, South Carolina. I've been asked to answer the question, how do I manage recurrent urinary tract infections? The first thing is I want to define the patient as having recurrent urinary tract infections, which is three hopefully culture-documented urinary tract infections in a 12-month period, or 2 culture-documented UTIs in the previous 6 months. The second thing I do is I try to determine the patient's menopausal status. If they're postmenopausal and it's due, in my opinion, to a lack of estrogen, I don't do a lot of investigation beyond that, but instead I start them on topical estrogen cream in the vagina. And I know that if I can re-estrogenize the vaginal epithelium, I can hopefully reestablish the normal bacteria that live in the vagina, which will then keep out the bad actors that cause, we think, the majority of recurrent bladder infections. If the patient's premenopausal, I will do a little bit more of an investigation. I may do an upper tract study, usually just an ultrasound of the kidneys. Again, I try to get culture documentation that these are truly bladder infections and not due to something else. And then if they're happening infrequently, I will usually just give the patient an open prescription for antibiotics. A lot of physicians are uncomfortable with that, but if you look at the literature on giving patients control over their own antibiotic use, it's actually less than if they have to go through a medical provider to get their antibiotics. If they're having very frequent bladder infections, say one every other week, once or twice a month kind of thing, then you have to decide if you're going to treat them either with symptomatic antibiotics or if you're going to try suppression. Suppression is always my last choice, and if I have to use suppression, I typically will start with something like macrodantin because I know it's going to have very little impact on the rest of the patient's flora, especially GI bacteria. And I usually start them on 1 a day, and I'll keep them on it for 6 months. If they get beyond that and these things are not working, then it becomes a little bit more of an investigation, a little bit more of a challenging patient. And oftentimes it's due to some very bad actor bugs, and then I try to get my infectious disease people involved to help me to come up with some sort of an antibiotic regime. That's how I manage recurrent bladder infections. Thank you.